like to thank the Society for allowing me to present our work on symptomatic improvements after reoperative laparoscopic hiatal herniorrhaphy at the University of Nebraska Medical Center. Nothing to disclose. And patients who undergo laparoscopic paraesophageal herniorrhaphy present with various esophageal and extraesophageal symptoms. The recurrence rate of the paraesophageal hernia is anywhere from 4 to 44%, with reoperative intervention required in 2.5 to 5.1% of patients. Prior studies have demonstrated conflicting symptom resolution with reoperative paraesophageal herniorrhaphy, sometimes requiring esophagectomy. The goal of our study was to determine symptom resolution after laparoscopic reoperative herniorrhaphy. And so we developed a frequency-based symptom assessment consisting of 24 esophageal and extraesophageal reflux symptoms. This was administered to the patients preoperatively as well as 6 months and 12 months postoperatively. And our scale was 0 was never, and up to 4 was several times per day. We upscaled if these patients fell in between. The composite score was then created, which was a sum of either the esophageal or extraesophageal symptoms. This data, as well as demographics and the type of surgery, was collected into a Microsoft Access database and subsequently analyzed with SPSS. We had a total of 195 patients in our study. We found that the average age was 53.8 and 42.6% of them were males. And as you can see, there was no difference between either the primary or the revisional as far as the age or gender. We did find that a larger percentage of our revisional patients had a toupee fundoplication or a door fundoplication as opposed to the primary surgical patients. And this is as a result of ineffective esophageal motility found in those. We also performed an alloderm hiatoplasty on the vast majority of our patients, and some of them had none. And so what we see here is basically all of our esophageal symptoms, and when we compare the 6-month or the 12-month postoperative patients compared to preoperatively, there was significant improvement in all esophageal symptoms. And we found that in our revisional patients, these patients tended to have more solid dysphagia, liquid dysphagia, or abdominal pain compared to the primary patients. And this is likely as a result of distortion of the esophagus necessitating the repair. And then subsequently, these patients subjectively had a greater improvement when compared to those that had primary surgical procedures. And these are our extraesophageal symptoms. Again, when you compare those that had primary repair or revisional repair as compared to preoperative, they had significant improvement as well. And the vast majority of these patients had greater improvement with revision when you compare them to the primary patients. So in conclusion, patients who undergo reoperative laparoscopic paraesophageal herniorrhaphy at an institution that has expertise in foregut surgery had excellent resolution of both esophageal and extraesophageal symptoms. Often these were comparable or even better to first-time laparoscopic paraesophageal herniorrhaphy patients. Thank you.